This week I will be covering airway management with a focus on suctioning and tracheostomy care. This information will come from Chapter 25 in your Clinical Nursing Skills and Techniques textbook. The objectives are to identify the indications for airway suctioning and the necessary equipment for sterile suctioning, compare and contrast nasotracheal, oropharyngeal, and endotracheal suctioning, demonstrate safe tracheostomy suctioning and care using sterile technique, describe the contraindications, complications, and unexpected outcomes of suctioning and preventative nursing measures, and to discuss delegation assessment, recording and reporting, evaluation of client response, and client education. We will begin with a review of the structures of the respiratory system. If you take a look at this slide, you will see an image on the left-hand side of the upper respiratory tract and the lower respiratory tract. The upper respiratory tract includes the nose, the mouth, the pharynx, the epiglottis, the larynx, and the trachea, while the lower respiratory tract includes the bronchi, bronchioles, alveolar ducts, and alveoli. So air enters, most times air will enter the respiratory tract via the nose. And the function of the nose is to protect the lower airways by warming and humidifying air, and it also filters small particles before they actually enter the lungs. From there, air moves through the oropharynx and the laryngopharynx and travels through the epiglottis, which is that small flap that's located behind the tongue that closes over the larynx during swallowing to protect the lungs from solids or liquids entering. Below that level, you'll have the vocal cords, which are located in the larynx. So air has to flow over the vocal cords in order for vocalization to take place. These are all important things to remember as we move forward. From the larynx, you will see the trachea, and the trachea is a cylinder-like tube that's about 5 inches long and about 1 inch in diameter. It has cartilage that's in a U shape that goes around it to keep it open, and yet still allow the esophagus, which sits behind it, to expand when swallowing. The trachea will bifurcate into the right and left main stem bronchi at a point called the carina, which is an area that I want you to remember as well. This carina is an area where it's very sensitive, so if it's touched with a suction catheter, the patient will start coughing vigorously. When we then we'll go further down into the right and left main stem bronchi. From there, it branches into bronchioles, down into the alveolar ducts and the alveoli, where gas exchange actually happens. The area of the image labeled B is of the ciliated mucous membrane of the airways. Cilia line the airway from the trachea to the bronchioles. These cilia beat rhythmically, moving mucus towards the mouth. You'll also see the globulate cells. These cells are the mucus-producing cells, and this mucus functions in, it actually traps debris and particles. There's usually just a small amount that's produced daily, and a person's usually able to swallow it, but there are some conditions where those globulate cells may produce more mucus, such as in the case of infection, and that might make it more difficult to expectorate because there's so much more, or if the patient's weak and has an ineffective cough, that might also affect the patient's ability to remove the mucus, or additionally if they're sedated. So those are just some things I want you to keep in mind as we go forward. So carrying on with airway management. The goal of airway management is to maintain adequate tissue oxygenation and protect the patient's airway from food, fluids, foreign bodies, obstruction of soft tissue. And this is done by maintaining the patency of the patient's nose, the upper airway, the trachea, and the lower airways. So there are some non-invasive ways to maintain airway patency and clearance, and those include adequate hydration, which is important to keep the secretions loose and thin so that they're expectorated a lot easier. If a patient's dehydrated, then oftentimes secretions become very thick, and in that case, harder to remove. Positioning is important for optimal chest expansion and to mobilize secretions. Nutrition will be another important aspect. Maintaining adequate nutrition will help to maintain muscle strength that's needed for coughing and deep breathing and healing. Chest physiotherapy is something that can also be used to maintain airway patency and clearance of mucus. This is oftentimes done by respiratory therapy. They use techniques such as percussion on the chest, position changes to mobilize secretions, maybe from side to side, Trendelenburg in some patients who are able to tolerate it. They can also use vibration tools that will provide a vibration over the chest to loosen secretions as well. Everyone learned about coughing and teaching our patients to cough and deep breathe during probably first semester. Deep breathing is important to make sure the alveoli stay open, and coughing to mobilize secretions, of course. Humidity is important. Maintaining adequate humidity will ensure that the secretions also stay thin. Decreased humidity can produce thick secretions. It can also make it you learned when you give supplemental oxygen to a patient. If you have a nasal cannula and you're giving more than 4 liters per minute, then you want to humidify that air because it sort of hurts because it dries the nose so much. So adequate humidity is very important. And remember, the function of the nose to warm and humidify. If we have a case where we're bypassing the nose, then extra humidity will be needed. Another tool that can be used non-invasively to maintain airway patency and clearance is incentive spirometry. You also learned about this. This prevents atelectasis in the lungs. And always remember incentive spirometry, incentive inhale. So that you're teaching the patient to actually inhale slowly and deeply and hold it for a few seconds if they're able to. And lastly, aerosol therapy is another non-invasive way to maintain airway patency. And with this type of therapy, bronchodilators can be given to open up airway bronchioles, and also corticosteroids to take down inflammation in a patient who has those conditions. More invasive techniques would be needed if the patient is not able to protect their airway or clear their airway on their own. And you can see a picture of some of the more invasive techniques on the far left. These are airway adjuncts. You'll see the oral airway, OPA. This moves sometimes the tongue will fall into the back of the pharynx and block the airway, so that oral airway will help to pull the tongue forward so it doesn't block. And then that would be in an unconscious patient. And then the device that's below the oral airway is a nasal airway. So this would go into the nose and down to the pharynx to keep the airway open. And those can be used in semi-conscious patients. The middle picture is of a patient with a yanker to remove secretions from the mouth. And just remember, when you're using that, you want to just gently guide it around the gum line. Be careful. You don't want to injure the patient's teeth or knock teeth out, so you have to be really careful to keep it around the gum line, and also don't push it too far back into the mouth to elicit the gag reflex. And then the last picture to the far right on the bottom is of a patient receiving suctioning of their tracheostomy tube. So that's a more invasive technique that we'll cover in later slides. In trying to provide patient-centered care, we must remember that artificial airways will alter the patient's ability to communicate. We will have to develop alternate means of patient communication and collaborate with the patient's family on how to best provide that alternate communication. There are some patients with tracheostomy tubes who can speak because they may have a speaking valve in place or a special tube that allows for airflow around the vocal cords. But if they don't, they may not be able to speak to you. Or if a patient has an endotracheal tube in place, they won't be able to speak. So you can do some things like ask yes or no questions. You would instruct the patient to nod their head or nod their head yes or shake their head no to the questions that you ask. So it could be something as simple as, "Hi, my name is Cherise. I'm going to be your nurse today. Are you Mr. James Smith? Yes or no?" And then he shakes his head. "Is your date of birth 10/12/1960? He shakes his head yes or no. "Your chart says that you don't have any allergies. Is that correct?" Shakes his head yes or no. You want to make sure that you explain everything that you're doing, that you let the patient know what to expect, because if you do that, that's going to decrease a lot of apprehension. If this is something that is new for the patient, they can be quite fearful and frustrated and anxious at times, just as they get used to it could be a temporary thing or it could be a permanent thing. So just be mindful of those things and be patient and take time to explain things to your patient. Another thing that you want to do is make sure that you perform a functional assessment. So if we're using alternative means of communication, head shaking, nodding head yes or no is really simple, but in the image you can see the nurse is using some type of like an iPad with the patient, some type of tablet to communicate. If you want to use a whiteboard where the patient writes on a little small whiteboard or give them pen and pencil, you have to test their muscle strength to ensure that they're actually able to write. If a patient wears glasses, ensuring that they have their glasses so they're able to see. Hearing aids, if they have those, making sure that checking with the families, make sure they're functional and they're working so that the patient's able to hear you. Also, you want to ensure that you're speaking to the patient in their native language. So there may be a need to get an interpreter as well. So all things you want to be mindful of and look into in order to provide patient-centered care to your patients who may have all artificial airways. Indications for airway suctioning includes removal of secretions, airways, providing airway clearance, improving oxygenation for the patient, improving noisy breathing, and if it's a deep type of suctioning, it will actually improve lung sounds as well. And this is important because if secretions aren't removed from the patient, they're more likely to be aspirated deeper into the lungs, which increases a risk for infection, respiratory failure, and ventilator associated events if the patient is on a ventilator. And this slide contains images of patients having different areas, different parts of the airway suctioned. You have oropharyngeal suctioning in the first picture, the top, and then there's nasopharyngeal suctioning, and then tracheostomy tube suctioning on the bottom. Now we are going to take a look at some different types of suctioning of the upper airway. We will look at oropharyngeal suctioning, nasopharyngeal suctioning, and nasotracheal suctioning. There is an image on the screen of oropharyngeal suctioning. That's basically suctioning the mouth, the pharynx. And then there's also nasopharyngeal suctioning, and you can see an image of that. It's where a catheter enters the nose and goes down to the pharynx. And lastly, nasotracheal suctioning is where the suction catheter enters the nose and goes all the way down to the trachea, so it goes deeper. Some indications. How do you know that a patient might need to be suctioned? If you see increased secretions or there's visible secretions in the airway, if the patient has respiratory distress as indicated by an increased work of breathing, increased respirations, bronchi when you listen to the lungs, there a lot of coughing, and decreased SpO2 are all signs. Now, as far as the technique goes, oropharyngeal, nasopharyngeal suctioning are all considered a clean technique. Nasotracheal is considered sterile. Even though you go through the nose, the end point is the trachea, which is considered sterile. So that would be a sterile type technique. So what the way that this is done, and this will be applicable for all types of suctioning that we mentioned. You want to sit your patient in a semi or high Fowler's. This is going to be the position for optimal lung expansion. Assess their vital signs, do a focused respiratory assessment, make sure you check pulse ox and leave the pulse oximeter on so that you can monitor the patient throughout the process. You're going to prepare the suction equipment, and you usually do that by setting it to a pressure of 100 to 150 millimeters of mercury for adults. You would also, connect the suction tubing to the suction, and then you check it. You would prepare the actual suction catheter, so you'll get a Yankauer, or if you're doing oropharyngeal, that would suffice. But if it's nasal, you'll need a small suction catheter, and there's actually a picture of a kit on the slide as well. But those suction catheter kits oftentimes come with a little sterile basin, so you take that basin and add some sterile normal saline to it, somewhere around about 100 milliliters, and this is used to clean the suction tubing after you're finished. So if we are doing nasopharyngeal or nasotracheal suction, you will need to lubricate the actual suction catheter with a water-soluble lubricant. If the patient has an artificial airway like an endotracheal tube or tracheostomy tube, you don't need to lubricate it with the water-soluble lubricant. This is only, again, if it's nasotracheal or nasopharyngeal. Before you suction the patient, you would just have them take a few deep breaths, or if they have oxygen in place, if they have a nasal cannula or a face mask right before you suction, you can increase the flow of O2. It's sort of a way to pre-oxygenate them and prevent hypoxemia. And then you would insert the suction catheter when the patient inhales, because at this time, when during inhalation, the epiglottis is open, and it's going to make that the suction catheter will pass a lot easier if during inhalation. Okay, and we'll just talk briefly about how far to insert the catheter. If you're doing nasal pharyngeal suctioning, you would insert the catheter somewhere around about 6 inches. You can measure it going from the tip of the nose to the angle of the mandible, and that's about how far it needs to be inserted. If it's nasotracheal down to the trachea, it's going to go a little deeper, maybe somewhere around more like 8 inches. Right before you do it, another good thing to have your patient do is to cough, and that will help to bring up any secretions that the patient's able to, and you can suction those out. When you insert the catheter, I didn't mention this, but when you insert the suction catheter, which you would connect to the wall suction, you insert it without applying suction. Suction's only applied when you are removing the catheter. And I will show you this process when we get to lab, and you only suction for 10 to 15 seconds. And then you allow the patient to rest. You put the oxygen back on them. And throughout the process, the pulse ox will be on the patient, and you would stop the procedure if the patient's heart rate increases or decreases 20 beats per minute, or if the SpO2 drops below 90%. Those are all signs that the patient is not tolerating that suction procedure, and you will need to stop. Okay, possible complications would be hypoxemia. And that's because when you're inserting a catheter into a patient's airway, you are occluding the airway for just a brief period of time. Remember, I said it's no longer than 10 to 15 seconds, but you are occluding and you are removing some oxygen while you're doing it. So the way to prevent hypoxemia is to decrease the suction time to 10 to 15 seconds, to make sure that you allow for rest periods in between suctioning as well, at least 1 minute, and that that you hyperoxygenate the patient by, if they're not on supplemental oxygen, you just have them take a few deep breaths before, or you increase the oxygen for 30 to 60 seconds prior to suctioning. Another complication would be bleeding. So if you're placing a catheter in through a patient's nose, even down to the trachea, there's a chance that there can be some trauma. So of course you never force catheters. You want to make sure that you don't use a suction pressure that's too high, so no higher than 150. And if you do get a small amount of bleeding, small amount is something that you can watch, but if there's a lot of bleeding, then you need to notify the healthcare provider. Another potential complication would also can be laryngospasm or bronchospasm, and irregular pulse rate. So we monitor our patients, keep them on the pulse ox throughout to watch for those types of things. Contraindications. If a suction catheter is to be passed through the nose, of course, you cannot pass a suction catheter through occluded nasal passages, so you would have to use your pen light to assess for patency before entering the suction catheter. If the patient has nasal bleeding, you could not insert a catheter through the nose. If a patient has had an acute trauma or surgery to their head, ears, eyes, nose, or throat, that's a contraindication to nasotracheal suctioning or nasal pharyngeal suctioning as well. If there's a bleeding disorder or coagulopathy, you cannot do it. If the patient has epiglottitis, inflammation of the epiglottis, croup, or an irritable airway, nasotracheal suctioning is contraindicated because it will cause intractable coughing, which will lead to hypoxemia and even more severe bronchospasms. And if the patient has had an acute MI, you would not want to suction them via the nasotracheal route because of the possible complication of hypoxemia that would add increased stress on the cardiac muscle, to get as much oxygen as possible. And additionally, there's a possibility of the vagus nerve being stimulated during nasotracheal suctioning. So this would lead to a vasovagal response where the patient could have bradycardia, which would also not be something that we would want in a patient who's had an acute MI. So now we'll take a closer look at artificial airway suctioning. Artificial airway suctioning is accomplished through an endotracheal tube, which is the top image on the left, or a tracheostomy tube, which is the image on the very bottom where tube is actually inserted into the trachea. This is done to maintain respiratory flow, to prevent airway obstruction, provide a route for mechanical ventilation in patients who aren't able to properly ventilate and provide ventilation and oxygenation. This is also done for removal of secretions and to protect the patient's airway from aspiration if they have an impaired cough or gag reflex. An endotracheal tube is inserted through the nose and mouth past the epiglottis and vocal cords into the trachea by specially trained personnel, such as a certified registered nurse anesthetist, respiratory therapist, rescue personnel, or the healthcare provider. Because of the route that this tube has to take in order to get to the trachea, there's a chance of trauma as it's being inserted. It provides a route for mechanical ventilation in patients who need that type of respiratory support. There's controversy as to how long it should stay in place. It's usually anywhere between 7 to 10 days up to 21 days. Some of the possible complications are laryngeal or tracheostenosis or cricoid abscess. In the image that's listed there, that's posted, you can see that this particular tube has an inflated cuff. This cuff serves to seal the airway around the tube and prevent aspiration of any oral secretions or gastric contents to the patient's lungs. It also prevents the escape of air from the mechanical ventilator breaths into the upper airway. So it ensures that when the patient's connected to the ventilator, those breaths will actually get down to the lungs and it won't be lost into the airways around. So they get the amount of air and the pressure that they need to keep their airways open. Our focus will mostly be on tracheostomy tubes. A tracheostomy is a surgical or percutaneously created stoma through the neck into the trachea. It can be temporary or it can be permanent. Tracheostomy is used when a patient requires prolonged mechanical ventilation over the 7 to 21 days. If a patient has any upper airway obstruction due to trauma or tumor. So if that upper airway has to be bypassed because a patient had some type of facial or neck trauma, a tracheostomy can be that airway for the patient. Additionally, if the patient has difficulty with airway clearance due to a spinal cord injury or neuromuscular disease or disorder, tracheostomy can be placed. They are made of polyvinyl chloride or silicone-based plastic. There are also some stainless steel or metal compounds that sometimes, not very often, but every now and then you may come across a metal tracheostomy tube. The advantages of an endotracheal tube the advantages of a tracheostomy tube over an endotracheal tube is that you'll have decreased laryngeal or tracheal injury. In addition to improved patient comfort, the patient will have more freedom in their activities of daily living. They can still eat with a tracheostomy tube in place. Some of them can speak if they have speaking valves and special tubes, and patients can be more mobile. And there is a link to a video on the bottom that you can watch in your downloaded slides. We won't watch it right now. This is an image of the different parts of a tracheostomy tube. You can see, we'll start with the flange, or sometimes it's referred to as the faceplate. It's the part that you see that sits on the actual neck. Then there's the outer cannula. The outer cannula has a cuff that's around it. The cuff is similar to the cuff that you just saw in the endotracheal tube. It's inflated in patients who are at risk for aspiration of gastric contents or maybe some mouth secretions. It's also inflated if a patient needs mechanical ventilation. This, because it will ensure that the air actually gets down to the lungs and the air is not lost around the tube. This cuff will put some pressure on the tracheal mucosa, so you have to make sure that the pressure is minimal enough to provide an accurate seal, but not too much pressure in which it might cause damage to the tracheal mucosa. So typically those pressures should not exceed 20 millimeters of mercury, and the respiratory therapists are the ones who oftentimes will come around and check this cuff pressure at certain intervals during the day. Depending on where you work, as a nurse, you may be trained to do that. But oftentimes it's respiratory therapists who will check that cuff pressure. And you will see there's a pilot balloon with a little tube that leads down to the cuff. The pilot balloon is where the cuff, where you insert a syringe and actually inflate that cuff. It has a one-way valve there. And let's go further and look at the other parts of the tracheostomy tube. Towards the bottom right is the hollow inner cannula. Think of the inner cannula as a liner. It will provide a quick way of removing obstructions or increased mucus from the tube. This is what actually collects the mucus. So that inner cannula can be disposable or it can be non-disposable. If it's disposable, then you simply remove it from the outer cannula and then replace it with a new inner cannula. If it's non-disposable, and we'll show you how to clean it when we do tracheostomy care, you would remove it, clean it, and then put it back in. The obturator is something that's only used when a tracheostomy tube is initially inserted. It helps to ease with insertion. It has a rounded tip that the provider will use to insert that tracheostomy into the trachea. And then the other part would be the tracheostomy ties. These are, in this illustration, they're strings. Oftentimes we use commercially prepared Velcro type holders, and it just it will help to keep the tracheostomy in place. Remember that if a patient has a tracheostomy tube in place, it is the patient's airway. This is how the patient breathes. So that airway needs to be protected at all times. And the tracheostomy ties is a part of what keeps it in place. So those need to be secure. When we talk about changing the ties out, we recommend having another person there just kind of holding the tracheostomy. If a patient coughs, they can cough that tube out. The cuff is going to provide a little bit of protection as well, but a forceful cough in a tube that's not properly secured can be coughed out. And that's a really big deal because, again, this is the patient's airway. So we'll look a little closer at cuffed versus uncuffed tubes. Again, the tracheostomy tube is cuffed to protect against aspiration of gastric secretions or aspiration of gastric contents rather, or aspiration of secretions from the patient's mouth. It also provides a direct flow of air to the lungs. If you can take a look at the image that's on the bottom right of the screen. In the first image, the patient has a cuffed tube. So just think of them being connected to a ventilator. The air goes directly into the lungs, and the image just next to it, this is a patient without a cuffless tube. So if air goes down into the lungs, it can also go out and back up through the trachea and larynx and out of the mouth. So there can be some air loss. So this would be important for a patient, again, who's on a ventilator and want to make sure that all of the breaths get down into the lungs where they should be. Uncuffed tubes provide a clear airway, but there's no protection against aspiration because you don't have that extra barrier. Just think of the balloon or the cuff tube as a barrier to keep things from getting down into the lungs. So you don't have that protection. And however, there are indications for a patient not to have a cuff tube. If a patient doesn't have a risk for aspiration, then that cuff can be deflated. Sometimes they might start out with a cuff inflated and it gets deflated later on once that aspiration risk goes down. When the cuff is deflated, the patient can swallow more easily because that pressure isn't on the tracheal mucosa and it's not putting pressure on the esophagus that sits right behind it, so they can eat easier. Patients with Uncuffed tubes can speak because air is allowed to flow up and over the larynx and the vocal cord, so they can actually have vocalizations. If they have a speaking valve in place, it's not recommended that patients put their, I've seen people do this, but put their fingers over an open tracheostomy tube, because of course there can be bacteria in the fingers. So a speaking valve is what should be used, and there's an image of that on the screen as well, or some type of filter. Okay, if a patient has a cuff that's inflated and it's okay to deflate it for them to eat or for them to talk, then you always want to have your patient cough first, suction go ahead and suction that tube in order to prevent aspiration. There are also fenestrated tubes. Fenestrated tubes have like little holes in them. There's also an example of that on the slide. And these holes will allow for air to also flow up and over the vocal cord so that a patient can speak. And patients who do not have a risk of aspiration can have fenestrated tubes. When it comes to suctioning these types of tubes, if they have an inner cannula in place, it's oftentimes fenestrated as well, so it has little holes in it. You would want to put an inner cannula in that doesn't have any holes in it, just a regular one, so that you can suction, because while you're suctioning, you don't want the catheter to get caught in those fenestrations and pull the walls of the mucosa of the trachea. Tracheal suctioning is skill 25-2. There are two different types of methods. There is the open method, which you will learn, where the trachea is just open to air. And there's also the closed method, or referred to as the inline method of suctioning, where the catheter is actually enclosed in a plastic sheath. So that one's not a sterile procedure, but the open tracheal suctioning is a sterile procedure. The suction catheter extends into the lower airway to clear out any mucus or debris. Some of the complications are hypoxemia, because again, the suction catheter, it should only be half the diameter of the actual tracheostomy tube, but there's a partial occlusion when that tube is down. Air is also removed during the process of suctioning, so that's something that we have to watch the patient for. And some of the interventions that we do in order to prevent hypoxemia is to hyperoxygenate our patients. And we'll talk about this more in lab, and you'll be able to see it, and I think it will make more sense. But we hyperoxygenate with a bag valve mask, with an ambu bag. You can hyperoxygenate that way. Or if the patient's on a ventilator, there's an actual button that you can push to hyperoxygenate the patient, and it's done for maybe 30 to 60 seconds. And you should do this really just right before you're about to suction, because if you hyperoxygenate them and you wait a few minutes, well, you've kind of taken away the benefits of doing it. So just right before you suction, you hyperoxygenate. We also limit our suction passes to no more than 3, and make sure that the patient gets adequate rest periods in between. So 1 minute in between suction passes, and that you suction for a short period of time, no more than 10 to 15 seconds at a time. Other complications are cardiac dysrhythmias, and these cardiac dysrhythmias occur because of potential hypoxemia, in addition to stimulation of the vagus nerve causing bradycardia. There can be changes in the patient's blood pressure. They can be hypo or hypertensive, bronchospasm, laryngospasm. There can be pain if the suction pressure is too high, so no more than 100 to 150. If the patient they will have discomfort, but it shouldn't be painful. So if they are complaining of pain, then you may want to decrease the suction pressure. Additionally, infection is another potential complication, and this occurs due to incorrect technique, not maintaining sterile procedure for the open method. And so it introduces microorganisms into the patient's respiratory tract, which is something we definitely want to avoid. And then bradycardia is another complication, and this is due to stimulation of the vagus nerve. So while a patient is being suctioned, we have to monitor them carefully. You will do a pre-assessment where you assess vital signs. You put the pulse oximeter on them, and you are watching that pulse oximeter for O2 sats and for their pulse throughout the procedure. If they're not tolerating the procedure well, you have to stop and put oxygen back on them, and then just wait a few minutes for them to recover. And then, of course, patient assessment will guide the frequency of suctioning. We don't suction at specified intervals. We let the patient assessment tell us. So some of the things we look for as indicators would be oxygen saturation less than 90%, visible secretions in the patient's tracheostomy tube, or lots of secretions like around the dressing that's in place, and their inability to effectively cough. Sometimes you can hear like coarse crackles over the actual trachea, or if the patient's having respiratory distress, increased work of breathing. Oftentimes patients will tell you it can, like it said, it can be uncomfortable. It shouldn't be painful, but maybe uncomfortable. But they'll if they've had it for a while, they'll tell you like that they need to be suctioned, or they will motion that they need to be suctioned. Some of the equipment that's needed for tracheostomy suctioning via the open method is a stethoscope, a pulse ox as well. These are to assess the patient before and during the procedure, and afterwards. You need a suction machine, so wall suction, check it, make sure it's functional. You'll need the connecting tubing for that suction machine, bedside table to place your supplies. You are going to need a mask, goggles, or face shield. I would probably recommend a face shield over the goggles. With the open method, the tracheostomy tube is actually open to air. So sometimes the patient might cough, especially when that tube is inserted. If it hits the carina, it's very sensitive. So the patient could cough, and sometimes respiratory secretions can come flying out of that tracheostomy tube. So you want to protect yourself from any microorganisms. You'll need to put a gown on if the patient's in isolation. You need a suction catheter that is the smallest diameter to remove secretions, no more than half the the internal diameter of the artificial airway. Now on to assessment before tracheostomy suctioning. As nurses, we begin assessment from the period that we walk into the patient's room. So when you walk in, you're looking at your patient's color. Is the color of the patient what's expected based on ethnicity, or are they pale? Does that indicate potential hypoxia? What is the patient's behavior? Are they alert and oriented? After you introduce yourself, when you ask them for their name and date of birth and allergies, and if they know what the date is or the day of the week, are they able to answer you appropriately? If they're not, then that might indicate hypoxia and a need for suctioning. Are they apprehensive or anxious because they're hypoxic or they need to be suctioned? Additionally, if they are anxious, or if they have an altered level of consciousness, just be alert that they may not be able to cooperate with the procedure, so you might need to get some help. Does your patient have risk factors for upper or lower airway obstruction, such as COPD or impaired mobility, decreased level of consciousness? Do they have an NG tube in place in which they are receiving tube feedings, or do they have a PEG tube where they're receiving tube feedings, which would put them at risk for aspiration? Does the patient have a decreased cough or gag reflex, which puts them at risk for not being able to protect their own airway, or decreased swallowing? Do they have a risk for ineffective airway clearance? which would be indicated by decreased level of consciousness, neuromuscular or neurological impairment, like a stroke. Have they had a stroke, a CVA, and they aren't able to effectively clear their airway because of it? Have they had surgery on their head, on their chest, or do they have any neck tumors that could affect their airway clearance? Are there any factors in play that may affect the volume or the consistency of their secretions? So what is their hydration status, their fluid balance? Are they overhydrated where are they in fluid overload where they're producing lots of mucus, or are they dehydrated which would make the consistency thicker and harder to remove? Is there a lack of humidity? Decreased humidity means that secretions will be dry and thicker and harder to remove. Is infection, does a patient have pneumonia? Do they have any infection in which might increase the amount of secretions and the thickness of them? So all things you want to keep in mind when you are assessing your patient. The closed or inline suction procedural guideline is 25-1. This is a procedure in which a multi-use suction catheter is connected to the patient's artificial airway. It can be connected to the endotracheal tube as is in the image on the screen, or it could be connected to the tracheostomy tube. Usually, again, this is for patients who are on ventilators. And in this case, you can see that the catheter has a plastic sheath that's covering it. So it's not a sterile procedure. The only thing that you have to do is thread that catheter down the endotracheal tube or the tracheostomy tube, and then provide suction. And it's still the 10 to 15 seconds as you're pulling back on that suction catheter. Some of the benefits is that there's a decreased risk of hypoxia and some of the cardiovascular complications as when compared to open suctioning, because you will not have to interrupt ventilation and oxygenation from the ventilator in this critically ill patient. So that's really important. It's a quicker procedure because it's not sterile. You don't have to put on sterile gloves. You don't have to put on a mask or goggles because it's closed. The tube won't be open to air, and there's a decreased risk of infection to healthcare providers because of the decreased exposure to the patient's respiratory secretions with this closed type of system. One thing to note, though, is that the incidence of ventilator-associated pneumonias is about the same as open suctioning with this procedure. Now, it's important to look at evidence-based practice. We'll take a look at what research says. Most of what's listed here has to do with artificial airways and ventilators. So with this, the closed method of suctioning endotracheal tubes is preferred over the open method of suctioning in patients who have had open heart surgery. Because it's a quicker process. It doesn't have to be sterile because the sheath is covering that suction catheter. The patient doesn't have to be removed from the ventilator, so they can continue with the oxygenation can continue. There's decreased risk of hypoxemia, and where it says no loss of PEEP, that's positive and expiratory pressure, something that is provided by the ventilator. You'll learn a little bit more about that when we do our lecture on ventilators. Another area that the evidence looks at is interventions in preventing ventilator-associated events and ventilator-associated pneumonias. So the recommendation is that bundles be created which will guide nursing practice on caring for patients on ventilators. Some of these interventions include keeping the head of the bed elevated at 30 to 45 degrees. That's going to decrease aspiration risk. daily interrupting the sedation of the patient who's on the ventilator to assess their readiness to extubate, to remove the tube, come off the ventilator. Again, when patients are on ventilators, we don't want them on any longer than they have to be. The longer they're on, the harder it is to get them off, the greater the risk for ventilator-associated events and pneumonias. Other interventions include starting peptic ulcer prophylaxis and DVT prevention prophylaxis, unless it's contraindicated. Daily oral care with chlorhexidine, because again, your mouth makes secretions as well, and the mouth is one of the dirtiest places on the body. You can have a lot of germs there, so patients have to have daily oral care with chlorhexidine. And another intervention includes delirium monitoring and management. For patients, we don't want them to become confused or combative and pull the endotracheal tubes or tracheostomy tubes out. And early exercise and mobility in the patient so that they don't lose too much muscle strength is important as well. Evidence also has guided the creation of products to decrease the risk of biofilm formation on endotracheal tubes, which in turn decrease the incidence of ventilator-associated pneumonias. This biofilm that sometimes forms on the endotracheal tubes will lead to the development of pneumonias. So products have been developed that will clean the inside of the tubes, as well as tubes that have a special coating that prevent this film from forming. Additionally, research advocates for automated cuff pressure control devices to measure the cuff pressures on the endotracheal tubes and the tracheostomy tubes. And that's been shown to lead to better airway care. As I mentioned before, respiratory therapy will usually monitor these cuff pressures, but you may work in a facility in which you're trained in the ICU and how to do this. Evidence no longer supports instilling normal saline when performing endotracheal suctioning. That was something that used to be done, but now it's not recommended. If there are microorganisms in the tube, this normal saline, usually it's not a whole lot that would be instilled, but it could push that further down into the lungs, so it's not longer recommended. And we'll talk about the fact that there's been some changes in the thought of how to suction. If we will suction continuously while removing the suction catheter, or if intermittent suction is recommended. So your book, still, it's I think the updated version of your book comes out sometime next week, the next edition. In this edition, it recommends intermittent suctioning. So the insert, and you'll see this in lab, but you will insert the suction catheter into the tracheostomy tube. While you're inserting that catheter, suction catheter, you do not apply suction. It's applied when the catheter is removed. So suction catheter inserted down into the tracheostomy tube until you meet resistance or the patient begins to cough. That's an indication that the suction catheter has reached the area of the carina. So then you pull back about 1/2 inch and you start suctioning. Your book says intermittent suctioning because you want to avoid damage to the mucosa of the tracheostomy. But some research has shown that it's best to provide continuous suction while you are removing that suction catheter, and you kind of go around in a circular motion as you are removing it. And again, remember, it's no more than 10 to 15 seconds that you're down there. But some research has shown that continuous suction is preferable, because with intermittent suctioning, you may have some secretions, but then when you release the suction, those secretions fall back down into the airway. So I'll show you how to do both. And when you get to your clinical sites, if you are able to perform this skill, you want to look at their policy and see if they are using intermittent suction or continuous suctioning. Some places have gone to continuous. Safety guidelines. You want to know where your patient is starting out. So baseline vital signs, baseline focused respiratory assessment, and O2 sat, so that when you go in later and assess your patient, you'll know if there are changes, you'll know if they need to be suctioned or if their condition is improving. You want to know your patient's past medical history. Do they have any disorders that put them at increased risk for obstructed airway, such as COPD or neuromuscular disorders or neurological disease, CVA. You want to know if your patient is a smoker, because smoking will alter that mucociliary clearance. So the cilia and the airway may not work as well, so the patient will have decreased ability to actually remove the mucus in the secretions in the respiratory tract. They may also have increased mucus production if they're smokers as well. You want to also know if your patient has an increase for aspiration of gastric contents in the lungs. So do they have altered level of consciousness? Do they have feeding tubes in place that put them at risk? Make sure the beds are at 30 to 45 degrees. Know the side effects of medications that your patient is on. So are they on any medications that may cause bronchospasm? Are they on any sedatives, any opioids that may make them sedated and less able to protect their airway or cough more effectively or move around to mobilize secretions? Want to use caution when suctioning patients who have had head injuries. Suctioning increases intracranial pressure. So that risk, if you have a patient who's had a head injury and they have an endotracheal tube in place, they're on a ventilator, or tracheostomy tube on a ventilator, the way to decrease that risk of increasing intracranial pressure is to hyperoxygenate and hyperventilate the patient prior to suctioning. This will induce hypocarbia, which causes vasoconstriction, and that in turn will decrease the risk of increased intracranial pressure. If you work in an area where you get a lot of trauma patients or ICU, you'll learn more about this hyperventilating the patients with head injuries. With nasotracheal suctioning, we talked about this earlier. Look into some of those possible contraindications, such as nasal trauma or surgery to the head, ears, eyes, nose, or throat, nasal polyps, deviated septum, in which it may be difficult to pass a suction catheter, and chronic sinusitis, where the patient may have a blocked nasal passages due to swelling. Always, all equipment has to be tested before use. So you're going to test your suction before you apply it to the patient. And that's pretty much it here. The suctioning of new artificial airways cannot be delegated to an NAP, nor can nasotracheal suctioning. There are some facilities, I don't personally know of any, but your book states that there are certain facilities that might allow NAPs to suction established artificial airways. I don't know, maybe perhaps a long-term care facility that a nurse has deemed the patient safe to do so. One of the things that the nurse will direct the NAP about is signs and symptoms of hypoxemia, and to report any changes in the patient's secretion. So if they are helping the patient up or giving them a bath, if they notice excessive secretions or if there's a change in color or odor, that's something that they can report. They're not assessing, they're just letting the nurse know if they see these types of things, these unexpected outcomes. Recording and reporting. You would record the amount of secretions, the consistency, the color, the odor, the size of the catheter that was used to suction, the route, the patient's response, any hyperoxygenation that was used, if it was just pressing the button on the ventilator or using an ambu bag. Document the pre-suction and post-suction vital signs and focused respiratory assessment, the cardiopulmonary status, any ventilation measures. Special considerations. Always teaching the patient will decrease apprehension in most cases. So let the patients know that you will have an increase in cough. We even encourage them to cough prior to suctioning. And remember, if you go down as far as the carina, they're gonna cough. So let them know. And you won't hear them coughing, but you can kind of see their bodies moving as if they're coughing, because if they have a cuff tube, you won't have the vocalizations. Let them know that they will have some discomfort, but it should not be painful. And some patients are on supplemental oxygen, some are not. So let them know about your attempts to ensure appropriate oxygenation during the procedure. If it's a pediatric patient, you use a smaller diameter catheter, no more. Use a smaller diameter catheter, and you use less suction. So instead of 100 to 150 in adults, it would be less than 100 millimeters of mercury in children. Additionally, the distance that the catheter is threaded down into the trachea is less. You go no more than half a centimeter beyond the tip of the artificial airway, and the suction time is no more than 5 seconds, whereas in adults it's 10 to a maximum of 15 seconds. For the gerontological population, just be aware of some of those possible age-related changes that you can see. The capillaries are more fragile, so they're more likely to have bleeding. So suction pressures may have to be less. There's a chance for skin breakdown because the skin is fragile, so the area around the stoma needs to be assessed very carefully. There's also age-related changes that happens within the lungs themselves that you need to be aware of. So there is a decrease in the elastic recoil of the lungs, decreased gas exchange as the number of functional alveoli decreases. Older adults tend to have a less forceful cough and less functional cilia for that protection against microorganisms and debris. There is also an increased incidence of underlying coronary artery disease, which increases the risk for cardiac dysrhythmias. So they'll need to be monitored very closely as well when suctioning. If a patient is at home, they need to be taught how to clean and disinfect the catheters that they're using for suctioning and how to clean the secretion collection container. They'll need to be taught that suction should only be applied for brief intervals, so no more than 10 to 15 seconds. And you have to have 1 minute rest periods in between, replace the supplemental oxygen, allow the patient to recover, stop if they put the pulse ox on and O2 sats goes down to less than 90, or the blood pressure, the pulse rate increases or decreases 20 or more beats per minute. All things that you want to teach them. And then no more than a maximum of 3 suction passes at a time. Tracheostomy care is another skill that you will do. Usually you will provide tracheostomy suctioning first and then provide tracheostomy care afterwards. This includes cleaning or replacing that inner cannula, securing of the tracheostomy tube itself with ties or commercially prepared Velcro holders, assessing the patient's skin around the stoma, inflating the cuff to the appropriate pressure, checking cuff pressures, and providing oral care for the patient. This is a skill that I will demo for you in the lab. Now we'll look at some of the equipment that's important to have at the bedside in case a patient has an emergency. Remember that the tracheostomy tube or the endotracheal tube, if that's what the patient has, is the patient's airway. So if that airway is compromised in any way, it can be an emergency, a medical emergency. So the patient can't receive adequate oxygenation. Some of the emergency equipment that should be at the bedside, you can see at the top of the screen, there are hemostats. Sterile hemostats should be at the bedside. This is to open the stoma in case the tube becomes, in case the tracheostomy tube decannulates, in case it comes out, you'll need those hemostats to keep the stoma open to insert another tube. You would also need to have a tracheostomy tube that is the same size that the patient currently has and one that's a size smaller in case you can't get the same size back in. You need to have extra suction catheters at the bedside in case the patient needs to be suctioned emergently. Some type of, you need to have a sterile normal saline at the bedside as well. That's used during suctioning, is also used during cleaning. You'll need a manual self-inflating bag or ambu bag at the bedside for to provide ventilations in the case of emergency. Also, if the patient needs to be hyperoxygenated, you would need that at the bedside as well. Unexpected outcomes are a partial tracheostomy tube dislodgement or decannulation. Decannulation is a complete removal of the tracheostomy tube, which is a medical emergency. If this happens within the first week of the stoma being placed, and at this time period, when the patient has a new tracheostomy tube placed, it takes about 1 week for that stoma to heal. So if the tube is accidentally removed, that opening can close rather quickly. So it's important to act quickly and promptly should this happen. So some of the signs and symptoms that may alert you to a tube dislodgement, a partial dislodgement, the tube may just come out a little bit and it may lodge itself in the area in between the skin and the trachea. You may notice an inability to pass the suction catheter or pass the tube. The patient might have subcutaneous emphysema near the incision site or the stoma, where air gets trapped under the skin. The patient might have respiratory distress or increased work of breathing, changes in signs and symptoms of hypoxia. They may look a little pale, respiratory rate high, changes in their pulse rate goes up to try to get more oxygen out. You may see use of accessory muscles. The flange, which is the face plate of the tracheostomy tube, may not be flush with the neck. Again, decreased O2 sats. And if the tube is dislodged, the patient might be able to speak around the tracheostomy tube because air is able to go up and around the larynx or the vocal cords. So call for help. Don't leave the patient. Again, stoma less than a week. This is an emergency, medical emergency. Surgery needs to be notified. You will provide ventilation via a bag mask, mask ventilation. Prep for intubation or a new tracheostomy tube. So if the tube comes out and the patient has an intact upper airway, meaning that the larynx is still intact, the airway going up through the pharynx and the nose, if all that's intact, then you can actually put a sterile dressing over the stoma and ventilate over the mouth and the nose. If the patient had some type of tumor or there was trauma and the larynx was removed, then you're going to have to try your best to ventilate through the stoma until you can get some help. In some cases, you can try to if you can't get the tracheostomy tube back in place, you can take the suction catheter, which is going to be smaller, insert the suction catheter through the stoma, and then try to insert the actual tracheostomy tube over the suction catheter. It can serve as sort of a guide for you. Another unexpected outcome would be tube obstruction. The tube becomes obstructed it could be obstructed with mucus, it could be obstructed with a clot if there's any bleeding postoperatively. like a mucus plug or like I said, a clot. Some of the signs and symptoms would be respiratory distress, inability to pass the suction catheter, or resistance when using a resuscitation bag. So you think your patient needs to be suctioned and you hyperoxygenate with the resuscitation bag and you meet a lot of resistance. That could be obstruction. So things to do would be to call for help. Don't leave the patient. Try removing, cleaning, or replacing that inner cannula. Remember, that's the liner that collects all of the mucus or what happens to be in the tube. If it's a mature site, its tracheostomy tube's been in place for more than a week, you can try to replace the tracheostomy tube if cleaning is not successful. That's if you've been trained on how to replace the tube. If it is an immature site, less than a week, check the placement. You have to notify the provider and prepare for invasive interventions such as intubation or for the provider to insert a new tracheostomy tube. Tracheostomy care is not routinely delegated to NAPs. However, be aware that in some settings, patients who have well-established tracheostomy tubes may have their care delegated to NAP. Generally, the NAP will be directed to notify the nurse if there's any changes in the patient's condition, if the patient has respiratory distress, changes in vital signs, if the faceplate's not flush with the skin when the NAP goes into the room, or if there's an abnormal color of the stoma or abnormal drainage, color, amount, odor, those types of things, that the NAP should report those should they see them or the patient lets them know that they're occurring. Recording and reporting. You'll do a focused respiratory assessment prior to doing your tracheostomy care. So you want to record that, document that before and after, the type and size of the tube that the patient has in place, the care that you provided, the type, color, amount, odor of secretions, how the patient tolerated it, any unexpected outcomes, and the interventions that you provided as a result, the condition of the stoma and the skin around the stoma, and any, like I said, any unexpected outcomes and how you dealt with those. Teach your patients that there are different types of tubes. Teach them about the particular tube that they have. If they have a cuff tube, what that means. If they have a fenestrated tube, if they have a speaking valve in place, they'll receive special instructions as well. How to care for that tracheostomy tube, making sure that it stays secure because it is the airway, their airway, the way that they receive oxygen. If there's bloody secretions, small amount of bloody secretions is something that can be expected with a new tracheostomy tube. A new stoma should be a small amount. If it's anything more than a small amount, then they need to report that to you, report that to the doctor. Caregivers are not to lift up face plates that are rigid because they can dislodge the tube. So just be careful. Don't move that around. Usually you just kind of take a Q-tip and go around it, and make sure that the ties are snug enough to keep the tube in, but not too snug as to put any undue pressure on the skin and cause an ulcer. So no more. You should be able to get 1 to 2 fingers under those ties. And we'll show you how to do that in lab. Special considerations with our older patient population. They have more fragile skin, more prone to skin breakdown from secretions that may come out of the tracheostomy tube or from pressure from the trach ties being too tight. So we need to be aware of that. Be aware of the fact that if the patient has impaired nutrition, they won't heal as well from their new tracheostomy tubes being put in place. Home care. Make sure the patient has adequate supplies to provide tracheostomy care as well as suctioning. Make sure that they have a backup in case they use electricity because they will need suction equipment. Some of them will be on supplemental oxygen as well. So making sure that supply, that they have enough of that supply as well. They need to know signs and symptoms of respiratory distress and stoma infections and how to report those to the provider. So in class, a couple of things I want you to think about, and we'll cover these next week, would be what is hyperoxygenation, Why do we do it? Look over the checkoff sheet and see if you have any questions there. Write those down. Think about sterile technique. There's one hand that stays sterile, one hand that's clean. And how long trach suctioning is done, how often can it be done, what guides when it is done, those assessments that we need to do for a patient prior to actually suctioning. And then we'll also, again, focus on tracheostomy care, how it's done, precautions to take, things to look out for.